into that room stuff. So we're going to go through and we're going to talk about atypical dysplastic nevus. Okay, so these are like all of the nevi that we talked about yesterday. However, this is more of that danger aspects that are out there. And then we're going to get into the malignant melanomas. Okay, there are 4 types of these melanomas, and each of them has key components that are specific for that type of a melanoma. So make sure that you pay attention to what we're talking about when we get into those individual ones out there. Okay, so dysplastic nevus, this is that atypical. Okay, again, you know that we're gonna give all of that ethnicity of the common or of this or that. Yes, we're gonna say white people, but we're also gonna get into some of the specific components that could be with those phototypes 6 and 7 and back and forth and yada yada. Okay, so 5% of the Caucasian population begin to appear near puberty and continue to develop past that 4th decade. So they're in my age. Equal incidence of both sexes. So it's not just male or a female with these. It can be either one back and forth. Okay. Usually these things are greater than 5 millimeters. They can be flat, or they can have in the center or in the middle of that nevus. They can have some of that elevated stuff. So that raised center that looks like a fried egg. Okay, so we will see those things. Okay, of course, A, B, C, D, E. Right, we're going to go through that numerous times because that A, B, C, D, E is that specific aspects. Yes, of course, we've got irregular, indistinct borders. We've got some of that darkly or irregular pigmented. So that's what makes us think and look and consider if we are having some type of a melanoma. Okay, distribution, back, upper, lower limbs, but you can see that underline right there is that sun-protected areas. So these dysplastic nevus we can see on the breast, the scalp, the buttocks, the groin. Diagnosis-wise, usually these things have that diameter that is greater than 5. Ill-defined borders, irregular margins, varying pigmentation within the lesion, presence of papular plus macular components, right? So like I said, that fried egg, you will see that macula that is out there, but they can also have in that center that of a papular there. For you to make that diagnosis, then at least 3 of these things have to be happening for us to make that of a diagnosis. Again, chart, it's just talking about what is of the common nevi that we talked about yesterday, and what are these atypical, those dysplastic nevus. We just talked about all that. Excisional biopsy with margins, if suspicious. Again, if we are doing some type of a biopsy, if we're doing a punch, a shave, an excise, like we always want to get some of the good skin come out of it too, so we're not leaving any of those cells located to regrow. TBSE every 6 to 12 months. Of course, we're always going to take those first pictures so that we can see if it is changes. Of course, we're going to be educating them about avoidance of the sun, screening for the family members. Hey, Dad, you better tell your kiddos one day they're going to have to look for these things. Okay, so that's there. And then obviously, this or where it's at, if we're getting up to that trigeminal nerve area, then obviously we are always going to send them to ophthalmology so that we can see if they're having some of that glaucoma or other eye aspects. So there's what they look like, okay? That's all over. We don't have to biopsy every single one of those things because they all look the same, right? So we're going to do some of the biopsies on top of the back, lower the back, you know, and just send those out. If those come out exactly and we just randomly picked one, then we know for sure that it's not melanoma, so we don't have to do the biopsy for everything, okay? Specifically, sometimes we want to look for that ugly duckling, right? We want to look for one that looks the worst, and that's definitely one of those things that we would want to do that. So where's the ugly duckling in here? Well, you can see the big guy right there, right? Big and dark and black, okay? These things are different than all of the nevi that we talked about yesterday, right? We talked about of that junctional compound. We talked about the dermal ones there, right? They had those borders which are clear. We can see the size of them. We can see the color. It's all one of a color. Well, these dysplastic nevus, they have those changes, right? So it's not easy to see all of the borders that are there, okay? We see some of the color variations, right? We can see that it's different. Where is that border? Where is that stuff at? Again, pictures after pictures. What's that one? The fried egg, right? So we see how we can see that nevi that's there, but then we get that papular area smack in the middle that is showing us dysplastic. Fried egg, okay? So that's all of the dysplastic nevus. Now let's get into the malignant melanomas, the bad stuff, okay? The death stuff, cancer. First off, we're going to go through some of the statistics out there, okay? So malignant melanoma, regardless if it's one of the four, it's the 5th most common cancer in men and the 6th most common cancer in women. Median age, 57. Death, 67. Males a little bit more because, you know, they will be running around outside. We know 10 times a greater risk for the Caucasians, more than what it is for us Hispanics and Asian, blacks. This is a percentage rate right here, okay? So it's got on here 35% personal history of atypical moles, which is what we just talked about with that fried egg, dysplastic stuff. Family history of melanoma and greater than 75 to 100 moles. So it's all over their damn back and body. Okay, so that's 35%. That's a higher risk than the 17, which is previous non-melanoma skin cancer. And then it breaks it down into those other ones going blah, 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 blah. So you could see a question talking about the greatly increased risk percentage. What could it be? Okay. Hink, hink. All right. Some more of those things here. These are all of the lower percentages, but they are part of the list that could be out one of those things. Okay. Of course, we know that it's more common with of our phototypes 1 and 2, and then it goes. It can be at risk for every phototype, but the greater risk is with those 1 and 2 up there. UV exposure, okay? I already tested y'all on this chart. I'm not gonna do it again, okay? So, yeah, happy y'all got it wrong the first time anyways. Damn it. I'm kidding. But
right in the middle.
That is just for you to remember, okay? Now, it's not going to be me asking you about phototype 1 verse 6 versus this or that. Now we're going to be leaning into more of the dark pigmented people or the light pigmented people, right? So, yeah, again, we're going to see some of those things. ABCDE, asymmetry, border irregularity, color variation, diameter, evolution change. Anywhere. The back is most common for men. Most common for women are the arms and the legs. non-cutaneous malignant melanoma, more common in the non-white population. So the mouth, the nose, the eyes, the penis, vagina, anus. Those are some of those other areas that can be happening. This one right here, let's go ahead and just put tattoos of this on y'all, right? So this is the ABCDE. You will remember this forever. Everything that we see over here is what we talked for the first stuff, right? But this is the bad stuff, right? That asymmetry, it's not round, it's not oval, it's not, in that area. It's, up and down, back and forth. Border, it's hard to see where that actual border is at. Like, does it end right here, or is it up there, or where is that shit? Okay, so that's the border changes. We've got color. It's not one color. We've got a black, and a brown, and a pink, and a blue, and it's all over the place. Diameter, it's greater than 5 millimeters, then we are concerned about that. And then evolution, is it changing? What did that first picture of it look like, and what does it look like now? Ugly duckling, again, it's just showing him out. Where's the ugly duckling on that one? Boom, there it is. How about that one? Boom, there he is. Okay? With malignant melanoma, right? Diagnosis, of course, if we think that it is something, we're going to refer them to dermatologists. The dermatologist can look at it. Dermatologist is going to have that beautiful little scope that they can use and look at and, get into that area, right? So those things are out there, okay? Y'all know that I am up here talking to y'all and want y'all to think about it from a primary care standpoint. What is it that y'all are going to be doing? ABCDE, ask about, does it hurt? Does it itch? Does it bleed? Do you get any crust? Do you get any pus or ooze? Ulcerations, erosions, we're getting into that stuff. We're going to ask them all about their medical history. So have you had sunburns? Have you had, medications that could be having some of that photosensitive stuff? What's your job? Do you work outside? Are you a lifeguard? I don't know. Like, what do you do that could have that? Prior skin cancers, family history, constitutional symptoms. Are we having fevers and chills? Night sweats, are you having some of those other things that are out there? Of course, we always want to document what we believe that their phototype is. We'll be doing that total body skin examination. So if you see that one ugly duckling, we're going to have to do a TBSE, and we're going to look head to toe all over. We'll be going through their scalp, through their groin, bottoms of their feet. We'll be, interdigital and back and forth. Those are things that we would want to do. Like I said, look for suspicious lesions, palm, soles, mucous membrane, scalp, labs right there, CBC, CMP, UA. Why are we doing labs? Because we're seeing if they're having some metastasis. Are they having some other things that are being caused by this cancer that is out there? And big thing there, referral to Derm. Okay, we're not going to be wanting, if we think that this is something that the ABCDEs are looking like, we don't want to shave that, we don't want to do that. We want the dermatologist to be able to see that once they get there, okay? Because a shave biopsy could leave some of those cells around, right? So it would have to be a complete excision, a widespread that gets all of that good skin out too, so that we know there, okay? So no shave biopsy. Yeah, derm, 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 derm. Prognosis-wise, we've got two type of diagnostic aspects. These are more of that measurements that are out there, okay? So we have Breslow microstage, so that's that depth. How deep does it go? Are we only in of the epidermis? Are we only in that dermis, or are we all the way down into that sub-Q area? So we're in that fat tissue. That's what the Breslow depth is. Clark level, that's just a 1, 2, 3, 4, or 5. Again, that's just calculating that stuff out. And we're going to talk about that more once we get to the end, okay? Curability directly related to tumor size and depth of the invasion, okay? So how far does it go? And again, once we get into the specific components of melanoma, we will be talking about if it's a radial growth or if it's a vertical growth, okay? So we are going to talk about that, and that will help us know what these ratings are. Like I said, there's that picture showing it, how far down it goes. So that's the survival, right? If it's in situ, so it's up on top, okay, that's pretty good. But if it's going further down, so vertical is a big aspect of this from a prognostic aspect, is how deep does it go? And again, now we're going to talk about the 4 types of melanoma, and then we'll specifically point out these things. So superficial spreading, that's the most common one. But then we get nodular, we go let it go, malignant, and then we have acral, right? So I'm going to point out highlights of what are specific to these ones out there. So the superficial spreading melanoma, SSM, that is the most common, 70%. This can happen at any age. It can happen anywhere, but most common of the upper back in both sexes, and then of the legs of women. Of course, we know ABCDEs are going to be with all of these things, so this is irregular, asymmetric, it begins as a flat or elevated. Hallmark is haphazard combo of many colors, so many colors. Nodules appear when lesion is greater than 2.5 centimeters, so this is superficial. Again, key components related to superficial spreading melanoma: asymmetric, irregular, brown to black macule initially, typically greater than 5 millimeters. This one goes through radial growth first. What is radial growth? That's spreading it out, so it's going this way, okay? We're going to talk about vertical, which goes this way, okay? So this one starts and undergoes radial growth first, evolves into black, blue, white, red, and undergoes vertical growth. It becomes elevated, so it starts to get that vertical, but it starts radial growth. And there's all of these pictures out there that just show how it starts. You see it gets into that radial growth first, and then afterwards, then it goes vertical, depending on how long it has been there. Look at that border. You can't even see where that border, that is asymmetrical. The border is hard to even see. Color, it's not one color, it's multiple colors, okay? Okay, so that's all that superficial spreading melanoma that is the most common. Starts radial, then goes vertical. Up next, we've got nodular melanoma. So 15 to 20%, so it's the next one. Completely vertical growth. This does not even do any radial. It can show up and it looks like a dot here, but it's still growing, but it's not spreading it radially. It's going deeper or rising up, right? So it can be of a papule, of a nodule. It can do those things out there. Can occur anywhere. 40 to 60s, male. 50% more higher than women. May not be pigmented, but most common dark brown, or red black. Commonly misdiagnosed because it could resemble some type of a blood blister, hemangioma, dermal nevus, SK, dermatofibroma. Those are those things that are part of the differential diagnosis. Again, dome-shaped, polypoid, pedunculated, irregular, brown to black papule or nodule, rapid size growth, and it's all vertical. It can also have some ulceration, it can bleed, it can do those things. So there's that picture of it. Starts off, and it doesn't expand radial because you can see that, what would we call it? Like the base stays the same size, but it's vertical growth, so it's getting bigger. So we can see some of that dome, polypoid. We can do those things there. So there you go. We can see that this one right here, it didn't radial growth. This probably started right about here, but then it started to grow up over there. So it's not radial. You got that red to black, an entire cheek. Again. There we go. So that is nodular, vertical. The third one, lentigo maligna melanoma. Okay, so have grandpa, because it's all older people, have them all let it go. It's got slow growth, right? They're old, they're slow, and it goes out. So most common is on the face, but they can also have that in the neck, arms, sun-damaged skin area. You get that brown to black macular pigmentation. It can also be a raised blue-black nodule. 5% of risk of becoming invasive, okay? So let it go, old, grandpa, slow. Breaks it down, showing this one does have some radial growth, so it's slowly radial, but then when it starts to become vertical, then you start to get that showing out. So on that bottom picture, the vertical growth begins right there. So that's that darker colored thing that's growing out, slow growth. So there's one on the ear, the cheek, same. Okay. Last one, acral lentiginous. A key component to this is we can see the patient be a dark pigmented person. So they've got that dark colored skin. So African Americans, Africans, you know, it's got some of those things out there that these are most common form in those dark pigmented people. The other key component of this is it's in hidden areas. It's not in areas to where you could have some of that sun exposure. So it could be on of their palms. We can see this on the sole, so it's up and under of the feet. They can have this up and under their fingernails, because when we talked about the nails in block 2, I talk about a specific finding that could be out there. It's called what? Hutchinson's sign. Hutchinson's sign is specific. Yes, then we talked about it only being referred to as melanoma, but it is this one right here. Hutchinson's sign is acral lentiginous. Very poor prognosis because it's in those places that aren't looked at, and so oftentimes it's already started to do metastasis, like it's already spreading and doing things out there. So yeah. So bottom of the foot, There's that Hutchinson. Souls. That's been there for a long time. And it's big. Up and under the nails, we can see some of that degeneration happening because it's eating it alive. So that's that, okay? So we talked about those 4 melanomas that are out there. The first one is the most common one, right? And then we got into those other aspects that are key components to it. So lastly, we're going to go through some slides over here that's just giving highlights to some of the malignant melanoma stuff out there, okay? Early stages of MM are diagnosed less often in the dark people, okay? Dark pigmented people, it's not seen, right? It's on the bottom of their feet. How many of us look at the bottom of our feet every day? You know, it's one of those things out there, okay? Stage 1 malignant melanoma was diagnosed in 39% of DPP versus 60% of others. Survival rates decline with delay of the diagnosis. Again, I said earlier that I am finished with the phototype colored people. Now this is more in association with dark and light. That's what's up here, okay? So in here, we can see 90% of the light can have melanoma on sun-exposed sites. 67 of the dark pigmented are not on sun-exposed areas, so they're hidden. That's out there. 40% of DPPs are on the foot, whereas only 2% of that is located on the LPPs. TBSE, we've talked about this numerous times. That's head to toe. Look at everything. So palms, fingers, soles, toes, subungual, mucosal. Of course, there's always a high index of suspicion. Educate that skin cancer is not a disease of light pigmented people. It's not only of the light-skinned people. It can be anybody. Something, this is just a slide. I'm not going to test you on this. We're going to stick with the regular A, B, C, D, E's. But this is just putting some highlight to one of those things that we have to think about with that dark pigmented people. So their age, 50s or 60s, brown or black band, change, so it's not the same as it was when it first started. Digit, most commonly involved with the dark pigmented people, right? They're having that Hutchinson sign. They'll be having that necrosis, like they're having stuff that's there that they just didn't pay attention to it. Cuticle, family history, da 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 da. This right here, this basically is all of the lectures that we did for block 3. So this tells you Nieves, dysplastic, radial growth, vertical growth, it's all into melanoma, starts to spread and gets out and all of that kind of stuff. So, yeah. Radial growth phase has a better prognosis, right? So that superficial melanoma, the very first one that we talked about, that starts radial, okay? So if they've got that radial growth, they have a better prognosis. But if it's getting into those ones that are having more of the vertical involvement, then no bueno. Metastatic development is rapid after vertical growth begins. So it'll spread out to those lungs, to the liver, to the brain, da 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 da. Talk about those criteria or those stages that are associated there, okay? Breslow, most important histologic determinant of the prognosis is the Breslow, determined by depth in millimeters at thickest point. So right smack in the middle, that would be where it's going into in, yeah. Extensive lymph node involvement, sentinel lymph node status, most important prognostic factor in lesions greater than 1 millimeter thick. So what does that Breslow looks like? Okay, so we can see this here, how we've got that dome, so we've got the nodule, we've got that stuff up in there, but then it's going to go all the way down, and then it's going to come in here. So we'll take that measurement from it all the way down to that point. Excision-wise, the dermatologist, yes, if it's just right up in here, they're going to cut that shit all the way down, okay? So they're going to cut more of it out so that they can make sure that we're not leaving any of these cells behind. So up and under there is that. Again, this is just some more of that prognostic factors out there. Yeah, pass. All right, final thoughts. Approximately 80% of malignant melanoma arise on areas normally covered by clothing. We talked yesterday and the day before that all of that sun exposure sites, because it's got it over and over, those are benign things. But the melanomas are oftentimes found in hidden locations. Consider TBSE on all patients at risk. So if you have a family history of that, Primary care provider has the greatest opportunity to catch an early melanoma and make a timely referral to dermatology. That is the last bullet of today's lecture.